This is a presentation of Turner syndrome by Elizabeth Reed, Zhao Feng, and myself, Michael Sim. Turner syndrome is a sex chromosome disorder caused by loss of part or all of an X chromosome. This is the only non-fatal monosomy and the most common sex chromosome abnormality in females. Turner syndrome occurs equally despite race or region in the world, occurring sporadically. As you can see above, less than 10% of cases are diagnosed prenatally. 20% found in infancy, mainly due to physical findings such as lymphedema, neck webbing, or congenital heart anomalies such as an atrial septal defect. And very few cases are found in early childhood. The highest prevalence of detection is found from ages 10 to 16, again, mainly due to the physical findings, such as delayed puberty and short stature. The 10% diagnosed in adulthood, again, are due to a physical finding, but at this point, it is generally amenorrhea. A normal egg and sperm cell start with 46 chromosomes. Then the egg and sperm cell divide in half, leading to 23 chromosomes each. When sperm fertilizes an egg cell, each with 23 chromosomes, that leads to a complete set of 46, or 23 pairs. The 23rd pair is called the sex chromosome. In females, the 23rd pair is XX versus in males, the 23rd is XY. However, in Turner syndrome, which again is only in females, there's only one X chromosome and the other is either altered or missing. Thus, this can be known as monosomy X. Chromosome error is considered unpreventable and sporadic. Therefore, a woman who has another child in general is not at an increased risk of having another child with Turner syndrome. There are three cytogenic classifications for Turner syndrome if we dive deeper. Non-mosaic, meaning a single X chromosome, monosomy X, which makes up the majority of cases, approximately 60%. Fragmented X or Y, and mosaic. Mosaic simply refers to the fact that there are some chromosome changes, but not in all the cells. The image provided demonstrates the possible X chromosome abnormalities that can be found in Turner syndrome. Now let's talk about what the clinician might see. If we take a look at the image on the screen, you will see the typical appearance of a patient with Turner syndrome. The most consistent characteristic found across the board for Turner syndrome is the patient being of short stature. Another typical characteristic that can be seen is referred to as the shield chest. In other words, the appearance of widely spaced nipples. If you were to look at the neck, you can also notice a short and webbed appearance. If you look at the arms, you will notice that the forearm is angled out and away from her body. This is known as cubitus valgus. One final common physical characteristic that can be found in Turner syndrome is Madelung deformity. Despite what you may be thinking, this has nothing to do with the lungs. Madelung deformity refers to the prominent ulnar head and the apparent volar subluxation of the wrist on the forearm. Next up, let's review the screening and management guidelines. This slide is a list of additional findings in Turner syndrome taken from our textbook. You will notice these findings include ears, eyes, nails, heart, back, the kidney, puberty, and infertility, along with nonverbal learning disabilities. Now, nonverbal learning disabilities include motor, visual, spatial, and social skills. The table here demonstrates the percentage of patients with particular traits. Now that we reviewed common findings, let's talk about screening and diagnosis. Turner syndrome is not part of the newborn screening exam. Given to its costly nature, requires a long time to be processed, and the use of specialized personnel. That said, Turner syndrome can initially be suspected from ultrasound findings such as lymphedema, heart, or kidney anomalies. Should the ultrasound raise suspicion of Turner syndrome, either a chorionic villus sampling or amniocentesis can be performed for diagnosis. Timing differs for each. A chorionic villus sampling would be between 11 and 14 weeks, as opposed to the amniocentesis, which is typically done after 14 weeks of pregnancy. Postnatally, the gold standard for diagnosis is a karyotype study. Should the initial be normal in a patient with high suspicion, a second karyotype should be performed using different tissue. Karyotype is simply a blood draw, which checks for the absence of part or all of an X chromosome. Finally, should any patient demonstrate typical characteristics with Turner syndrome, they should be screened without hesitation. Now let's talk about the management. Here we have a table from UpToDate with the recommendations for Turner syndrome. After a confirmed diagnosis has been established, further management encompasses many aspects, such as monitoring for associated abnormalities, which can be seen a wide range from cardiac, hearing, eye pathology, along with learning disabilities, just to name a few. This table represents the recommendations for screening other than cardiac and neuropsychological. A comprehensive cardiac assessment by a cardiologist is recommended, given those with Turner syndrome are at increased risk due to possible comorbidities of renal abnormalities and hypertension. Possible malformations include an aortic valvular disease, aortic arch anomalies such as coarctation, pulmonary or systemic venous abnormalities, ventral septal defect, and hypoplastic left heart syndrome. Turner syndrome patients are at further risk for aortic dilatation and dissection. Cardiac management would include an echocardiogram in infants and children and an MRI in older girls and women. Endocrine diseases are also more commonly seen in Turner syndrome patients, as they're more likely to obese, have insulin resistance, type 2 diabetes, and hypothyroidism. Laboratory tests for those 4 years and older include a TSH to screen for chronic autoimmune thyroiditis, a TTG with total immunoglobulin to screen for celiac disease. Those 10 years or older, a fasting blood glucose, A1C, ALT and AST, serum creatinine, and urinalysis should be completed given the risk of diabetes, fatty liver disease, and kidney dysfunction. As you can see from the table, a diagnosis, weight, BMI, blood pressure, thyroid test, a renal ultrasound, audiometric evaluation at 9 to 12 months old, an ophthalmologic exam at 12 to 18 months, a dental exam if care with dentist has not been established, checking for congenital hip dysplasia in newborns, and a skin examination. After diagnosis and in childhood, weight, BMI, blood pressure, thyroid function tests beginning at 4 years. Liver enzymes and A1C after 10 years of age, vitamin D every 2 to 3 years after 9 to 11 years of age, a celiac screening starting at 2 years and every 2 years, audiometric every 3 years, an ophthalmologic every 3 years, a skin exam annually, and an x-ray of the spine beginning at 5 to 6 years, and again during the puberty ages, 12 to 14 years of age. Feel free to review the screening recommendations for adults.
Now we will discuss how puberty is affected by this disorder. Primary hypogonadism is one of the most common features of Turner syndrome, as demonstrated by lack of pubertal development and primary amenorrhea, or pubertal arrest with secondary amenorrhea, in approximately 90% of Turner syndrome individuals. Because of the broad range of gonadal dysfunction, it can be difficult to predict which girls will have absence of puberty and which will have spontaneous stellarchy or even menarche. Pubertal development should be assessed with serial examinations throughout childhood and adolescence. Serum anti-Mullerian hormone, or AMH, contraceptions appear to be useful for predicting future ovarian function. We measure serum follicle stimulating hormone, or FSH, and AMH at around 10 to 11 years to help estimate ovarian function, detect impeding ovarian failure, and detect the need for estradiol replacement. Next, we will briefly discuss the medical management during puberty. Estradiol replacement therapy usually should be initiated if there is no evidence of breast development by the age of 11 to 12 years, and or if gonadotropins are elevated or AMH is low. Ultimately, almost all girls with Turner syndrome need supplementation with estradiol. This includes the 15 to 20% of girls with Turner syndrome who experience spontaneous puberty, which may persist for some time, but which usually is followed by primary ovarian insufficiency or premature ovarian failure. The objective of estradiol replacement therapy is to mimic the normal progression of puberty while maximizing growth potential with minimal risk. Later, cyclic progestins are added to the regimen to induce cyclic uterine bleeding and prevent endometrial hyperplasia. To optimize breast development, it is recommended to continue estradiol monotherapy for up to 2 years before adding any progestins. Next, a brief statement about fertility and Turner syndrome. At this time, even with treatment, most women diagnosed with Turner syndrome are infertile because of ovarian follicular depletion. Spontaneous pregnancies are occasionally seen, but a number of women now undergo in vitro fertilization or IVF with donor oocytes to try to conceive. However, risks are involved, and this will require preconception counseling and evaluation. Immunizations and Turner syndrome. At this time, there are no contraindications with routine vaccines and the diagnosis of Turner syndrome. Follow the CDC immunization schedule as recommended.
Let's talk about the gender differences in Turner syndrome. As it was mentioned earlier, Turner syndrome is a chromosomal disorder involving a complete or partial absence of the second sexual chromosome in phenotypic features, such as short stature and premature ovarian failure. Turner syndrome is a female-only genetic disorder that affects about 1 in every 2,000 baby girls. A girl with Turner syndrome only has 1 normal X sex chromosome rather than the usual 2 X sex chromosome. This chromosome variation happens randomly when the baby is conceived in the womb. It is not linked to the mother's age. Males with 1 missing chromosome X is usually not viable. That's the reason why Turner syndrome is usually in female. Changes in Turner syndrome as child ages. Cases of Turner syndrome sometimes are discovered incidentally during the CVS sampling or amniocentesis done for either advanced maternal age or for suspicion about congenital abnormalities noted on the fetal ultrasound. During the childhood and adult stage, there are possible comorbidities such as cardiovascular abnormalities, aortic dilation, hypertension, cognitive function and learning disabilities, and tympanometry and audiology disorder. Sometimes patient can have scoliosis and kyphosis, renal disorder, and urinary tract infections. Ophthalmology concerns and edema is also present in the childhood and adult stage. There are other comorbidities such as celiac disease, autoimmune thyroiditis, liver disease, metabolic syndrome, vitamin D deficiency, and gonadoblastoma risk. So it is very important to monitor during the childhood. The pubertal development should be assessed with serial examination, as it mentioned earlier, throughout the childhood and adolescence. And growth hormone therapy and estradiol replacement can be considered if it's needed. The cryopreservation of ovarian tissue and all the oocytes from the selected pre-adolescents or adolescent girls with Turner syndrome is under investigation. It is a new technique that might permit reproduction later in life. Also, we need to pay attention to when the Turner syndrome child transition to adult care. The loss to follow-up is very common. This will lead to insufficient monitoring of comorbidities and the lack of estrogen therapy or other interventions. So the potential long-term complications of Turner syndrome, strategies and resources for managing learning disorder, and resources for psychosocial support should all be provided. Anticipatory guidance for the child and the family. As a nurse practitioner, we have the knowledge about what kind of disease is Turner syndrome, and those information should be very well communicated with the family and the child so that they can make informed decision about how to take care of their health. So the communication should include what is the Turner syndrome, what are the symptoms, what kind of tests can be done, and how is Turner syndrome treated. And patients usually want to know if the person with Turner syndrome can have child or not. And all those information should be very well communicated with the family. Those are our references. This ends our presentation about Turner syndrome. Thank you for listening.